People talk about getting the baby to move down, so they use gallbladder 21 anytime after 40 weeks to move the baby into the pelvis. So basically, when the cervix is ready, I think of large intestine 4 as promoting the baby to go lower. I just want to say the baby does not need to go lower in multips. If it's her second baby, the babies can descend right just as labour starts. So it's only in primips that it's important that the baby engages, usually. And when the baby doesn't engage, I don't want to push that baby down. I actually want to leave it alone, because sometimes it's in a posterior position and you'd want the baby to turn before descending. And the reason, why is that baby not descending in a primip? And that's a good question. Why is it not? And is it because it's not yet in the right position to come down? Or is it because when it tries to come down, there's a bit of tension on the cord, there's something happening, and it pops back up again and says, oh, no, no. And then when they go into labour, these babies get distressed, and then they require caesarean sections. So the feedback from the midwives has been that even when they try and get the babies to descend, if they don't descend, sometimes it's because there's a reason why that baby's more comfortable higher in the pelvis. So I don't feel comfortable trying to get acupuncture to move it down. I work more with trying to get them to change positions so that they can get into a good position. So again, we just looked at this study when we looked at this is the latest one about, again, I think you can trigger contractions and you can trigger that more spontaneous labour, but I want to see natural birth rates increase, natural vaginal birth rates increase. And I think that is, to me, that is an important part of our practice that we need to think about. And can we be certain that if we stimulate labour at 40 weeks when the woman was going to go to 41, before she was medically induced, that we've actually done that woman a positive thing. So what's our scope of practice, and what are the natural vaginal birth rates for a woman you induce, and are your induction statistics any different from a medical induction? That's my questions really. And research is just about asking a question and then you answer it. I'm really happy if people could come to me and say, these are my practice statistics. This is what I do. I use electroacupuncture and Moxa on bladder 32, and these women go into labour and this is my natural vaginal birth rate. Please feel free to share those with me, because I think that would be really interesting. As I said, I don't use electro, so maybe that's, what's happening. But I just want to see something concrete rather than just the positive stories where it works for women without following people up. Hospitals, independent midwives, obstetricians, they have to give data. They do collect their data. Now, when I asked groups whether they collect data, very few people are collecting data about pre-birth, about acupressure, about their inductions. So even when people say yes, they're not collecting data that would be acceptable to share with a midwife or as somebody who was an obstetrician, because it's very vague. So again, I come back to that. So no specific details. No, you've got to have primips and multips. You've got to have the difference between inductions and whether it's pre-birth. Does that make sense? So it's sort of like that data that I showed you. So I think this is what I want to be able to say next year, or 5 years, or whenever we sort of keep on collecting data. I would like to be able to say to people, which is what I try and say to the people I deal with, the data does not show that acupuncture induction is useful, how they've performed it in the studies, and that's because acupuncture is a complex intervention. I don't do what they do in those studies. They are just using, the research is flawed because they're only using it to stimulate contractions. This is not my clinical practice. That ideally, we use individual diagnosis to promote beneficial effects, and there is no research to show that, but our clinical feedback suggests that this is useful. That's what I would like to wave a wand around and magically happen. That's the argument I'd like to make. And that we do have, however, there is some research about the Bishop score. And that is about making the baby the position. So I've got a thing of the Bishop score. courtesy of Sarah. So we've got here, this is a Bishop score you can talk about, that we do have evidence for this. Cervical ripening, and we can make a thing about effacement, dilatation, helping the baby moving into a good position, posterior, anterior positions. Clinical feedback shows that, this is something we try and do in clinic, is get the baby into a good position before the contractions start. Clinical, we've got some research evidence to show that acupuncture is helpful to help the cervix ripen before acupuncture starts. So ideally, I would like statistics to be that there is no difference in the onset of labour, that we're not pushing women into an earlier labour, but when they go into labour, they have increased rates of vaginal birth, decreased length of labour, decreased oxytocin if they need to be induced, decreased epidurals, decreased ventouses and forceps, and decreased cesarean sections. Correct? Wouldn't that be a good wish list to say this is what our medicine does? And that is actually true. We do have some evidence for that, but it is using acupressure. And I came back to that on Friday when I talked about that study. So that's why I'm so keen for people not to ignore the acupressure, because that is what acupressure is part of an antenatal program. And I won't go through it again because we went through it this is what it did show. And this is what we want. So if you're not giving out that acupressure homework as part of your program, please do, because this is what we want. So this also, this is the small observational study I did with the midwives. I mentioned it briefly. When they came back to me, because I was having follow-up meetings after the first couple of courses, and they said, this is changing our practice. Please come and present at our midwifery conference. And I thought, well, I didn't really like presenting, and I thought, well, let's gather some data. So myself and another midwife, Sue Lennox, we sent out some sheets to the midwives in our area, and we said, please tick the boxes for if you're using pre-birth, and then follow it up. And you'll follow up your outcomes, because we can follow it up in the midwifery databases. So we saw that the midwives, there was 14 midwives, they saw 169 women in 4 months. And again, that is the power of those women getting access to treatment that many of them would have not have come and paid for. And you can see, I was concerned because they were using spleen 6 on almost everyone, because they were all primips or women who'd had a difficult labour. Those are the women they wanted to use pre-birth on. And they saw spleen 6 from their experiences of using it with acupressure. I had one midwife very early come back and tell me, I can tell who's done the acupressure homework on spleen 6, because if they have done it every 2 hours over like those 3 days, there has been changes in the cervix that are beneficial. And if they haven't done it, the cervix stays much the same. And so that they very quickly got around that spleen 6 was to ripen the cervix. And I had a really nice story just recently of a midwife, and she had done the first part of the course. And what had happened is there was someone who was going to be medically induced, and so they were getting them to ripen the cervix. And she said the partner was doing it at night. So he was getting the woman's foot while she was sleeping and pressing on the spleen 6, supposedly too early during the night. And she said that woman, the cervix was 5 centimetres before she even had a contraction, a primip. And she went on to have a really nice birth. So just that idea that they feel, I did get lots of feedback about spleen 6 being really useful to ripen the cervix. So I was a bit concerned, were women coming into labour earlier? Because spleen 6 was one of those points you shouldn't be using a while, historically. But no, you can see from the bell curve, that is exactly what you would expect. The women weren't all coming into labour earlier. What the midwives were doing is they were not doing large intestine 4 very much at all, or bladder 32. They only did that just when they had to. Their main treatment was getting the baby into a good position and using Moxa on bladder 67, bladder 60, spleen 6. This is all the emotional points they have. But they were using them. Like 50% of the treatments were emotional stuff. Ligaments, gallbladder 34, stamina, stomach 36, cervical ripening, that's the other thing you can do. So sometimes people have got rigid, hard cervixes. Sometimes this is when they've had the previous surgery on their cervixes, and they know, the midwives feel it's going to be harder for them to actually ripen up. So you do that C4 going down to CV2, or REN4 going down to REN2. It's very nice on a pregnant belly. I'm sure I've got a picture of it somewhere there, because you're not really finding REN4, it's just down, and you can practice on a banana, like it's just subcut down and it slides down, and you're really directing chi towards the cervix. So that's another thing you can use to ripen the cervix. And how some of the midwives don't like using the long 1.5 inch needles, so they'll put in like 3 little half-sun needles going down, so you're free. They think that works well, so you're free to do that as well. And 60% were other points other than this large intestine 4. So this whole idea that spleen 6 was used on every woman, large intestine 4 was only used in 55% of their treatments, bladder 32 was only used occasionally when they needed to really stimulate labour. And this is what we found. I mean, it's a small observational study, but it mirrored the midwifery feedback that there were less inductions and there were less caesarean sections in both primips and multips who had the pre-birth acupuncture. Now, we got that published. We had gone to the statistician at the hospital, but they weren't interested in us. But once it was published, the statistician was interested in breaking down our figures, because what we'd compared was 169 women, small group, with all the women in Wellington giving birth over the year. Does that make sense? So it's not very precise. So he broke it down to all the women giving birth at the same time, that same 4 months. And what he found was, I've got the email, that we got statistical significance for reduced inductions for both multips and primips, and we got a statistical significance for induced caesareans for both multips and primips. And that's why the midwives come and do these courses, and that's why they like pre-birth acupuncture. So what we're looking at here, to me, is instead of doing an induction, is this whole cervical hormonal priming. So for those of you, this is what's happening to the cervix is that it's often I'll just finish, but we will have some questions. Yep. So basically, the idea is that the cervix sort of looks like this, and obviously in a woman having a second baby, it's slightly different. It's slightly shorter. But it is kind of thick and it's protecting the baby. So it's kind of and the uterus is an amazing muscle, because it actually pulls up at the bottom and has contractions that going down like this at the top. So most muscles they stretch and release, contract and release. But the uterine muscle is really special. And